Hi, I'm Dr. Siddiqa Ozaal, Senior Registrar in Chemical Pathology in National Hospital of Sri Lanka. Today I'm going to present a case series on hypokalemia in the topic of lab as a detective in uncovering hidden causes of hypokalemia. At the end of the presentation, I would expect you to know what is hypokalemia, why it is so worrisome, what are the causes of hypokalemia, and how the laboratory helps in diagnosing as well as in the management of hypokalemia. Without any delay, we'll get into the topic. Hypokalemia means reduction in potassium level. Depends on the numerical value. It can be classified as mild, moderate, and severe. Depends on the severity and the onset of hypokalemia. The patient can be completely asymptomatic or present with muscle cramp, weakness, and fatigue, or even with life-threatening respiratory failure and cardiac arrhythmia. It is very important to identify the root cause of this electrolyte imbalance because simply supplementing the patient with potassium is not going to add much benefit to the patient. We see how the biochemistry laboratory plays a role in this. Today, I would like to present the stories of four different patients who were referred to our biochemistry laboratory for hypokalemia workup. They all had four different presentations. Our first patient is an elderly female found to have hypokalemia following surgery. With the background of thyrotoxicosis, she was suspected to have thyrotoxic periodic paralysis. Our second patient is an apparently well male presented with polyuria. So, the polyuria workup was planned in this patient. Our third patient is a young girl presented with Cushingite features and she was suspected to have Cushing syndrome. The fourth patient is a young hypertensive male presented with flaccid paralysis. So, the top of his differential diagnosis was any neurological pathology. Our first patient is the one who was suspected to have thyrotoxic periodic paralysis. But she had persistently low potassium level even after normalization of her thyroid function test. So she was referred to us for further workup. Her TTKG more than 4 in the presence of hypokalemia confirms renal potassium wasting. Her 24 hours urinary studies revealed urinary magnesium loss and there was low urine calcium excretion. Apart from this, she also had compensated metabolic alkalosis. Her renal function test was normal with a normal ultrasound scan KUB. Her hormone profile revealed high direct renin concentration and a thyroid stimulating hormone and 9 a.m. cortisol were within limits. So, according to Krediger diagnostic criteria, she had chronic hypokalemia with inappropriate potassium loss, metabolic alkalosis, hypomagnesemia, hypocalciuria, high plasma renin activity, and normal renal ultrasound scan. So, she was diagnosed to have Dittelman syndrome, even without performing a genetic study. It is very helpful in a developing country like Sri Lanka, where the resources are so limited. Our second patient is a 63-year-old male presented with polyuria. Like the first patient, he also had high TTKG and there was evidence of renal magnesium loss. But unlikely to the first patient, he had metabolic acidosis with concomitant paired urine pH was more than 6. So, without performing acid load testing, he was diagnosed to have distal renal tubular acidosis. His biochemical profile also showed high albumin-corrected calcium, low phosphate, and high ALP levels. Consequent hormonal profile showed vitamin D deficiency, which was treated with 5,000 international units supplement. He also had very high PTH even after normalization of this vitamin D level. His neck imaging confirmed right side lower parathyroid adenoma. So he was diagnosed to have primary hyperparathyroidism. He underwent selective parathyroidectomy for his parathyroid adenoma. Intraoperative PTH monitoring showed 50% reduction of PTH levels from his baseline. According to Miami criteria, successful removal of the gland was confirmed. Post-operatively, his hypercalcemia and features of distal renal tubular acidosis were reversed, which showed that his tubulopathy was due to primary hyperparathyroidism. Moving into the next case, this patient is a young girl presented with Cushingoid features and underwent Cushing syndrome screening. Overnight dexamethasone suppression test was not suppressed. With limited resources, we were not able to perform the late-night salivary cortisol level and the urine-free cortisol, which were used in the Cushing syndrome screening. She also had a high level of midnight serum cortisol, and a single-dose high-dose dexamethasone suppression test showed a 50% reduction in the cortisol level. She also had very high level of ACTH that confirms her ACTH-dependent Cushing. To find out the source of ACTH secretion, the treating team ordered MRI brain, which showed a pituitary microadenoma. But still, we are not sure whether is it a secretory tumor or not. So we performed inferior petrosal sinus sampling in this patient. With a successful cannulation, it confirmed a ACTH secreting pituitary tumor. So she underwent transsphenoidal resection. Her post-operative period was uneventful, and currently she is on endocrine team follow-up. Our last patient is a young hypertensive male who presented with flaccid paralysis and found to have spontaneous severe hypokalemia and metabolic alkalosis. His plasma aldosterone concentration was more than 15, plasma renin activity was less than 1, and he had very high level of aldosterone-renin ratio. He was diagnosed to have primary hyperaldosteronism without performing a confirmatory test with all these clear-cut evidence. His imaging showed left side adrenal adenoma. Again, to confirm whether it is a secretory tumor or an incidentaloma, we performed an adrenal venous sampling in this patient. With successful cannulation in adrenovenous sampling and a lateralization index of more than 2, it confirms that there is a left side aldosterone secreting tumor. So he underwent left side adrenalectomy. The postoperative period is uneventful, and currently the patient is on endocrine team follow-up. From this case series, we can understand that hyperkalemic patients can present in different ways. The laboratory is not merely a supportive tool but a frontline detective in diagnosing hidden causes of hypokalemia. Biochemical markers like TTKG, blood gas analysis with paired urine pH, and hormonal studies help to differentiate different etiologies for hypokalemia. Timely structured interpretation of laboratory data can significantly impact in patient care as well as in the outcomes. Before we wind up, I would like to thank ISCC Task Force of Young Scientists for giving me this opportunity to present this case series. My trainer, Dr. Gaya Katulanda, consultant chemical pathologist in National Hospital of Sri Lanka, and postgraduate trainees, medical officers, and medical laboratory scientists in Department of Chemical Pathology in National Hospital of Sri Lanka, and last not least to the treating clinicians and the team of all patients. If you have any questions, I'm happy to answer. Thank you.